Thank you so much. I'm sure you can see me. My name is David Mukunya, and I am a medical doctor by background, but now doing maternal and child health epidemiology. I'm going to present my work titled The Effect of Neonatal Sepsis on Neurodevelopment of Infants at 3 to 6 months in Bale. And it's a cohort study, I would rather call it a pilot cohort study, nested in the baby gel trial. And we have a number of funders. The primary study is funded by EDCTP, and I'll say something about it. The imaging part is funded by NIH, and then sort of like the coordination and follow-up, and yeah, it's like Thresher who funded the idea, but then we liaised resources from EDCTP and NIH. So we all know that about 250 million children in low and middle income countries do not fulfill their neurodevelopmental potential. And this can result in poor school performance and really perpetuates poverty. And the goal and the challenge we have is to develop interventions that can promote their cognition and neurodevelopmental outcomes. And these need to be provided early because we know the optimal time for intervening is 0 to 3 years of age. That is really the optimal time of us intervening. So it's critical for us to identify factors for risk factors for neurodevelopmental delay. Yeah. So one such factor is neonatal sepsis. We know that neonatal sepsis, when a child has sepsis, sometimes that inflammation proceeds to the brain and it can result in developmental delay. We know that there is altered zinc homeostasis, which also results in neurodevelopmental delay. And there's also downregulation of proteins used in synapse formation. Yeah. And furthermore, we know that there is lipopolysaccharide-induced hypomyelination of the prefrontal cortex, but also there are other indirect effects of neonatal sepsis, like decreased nutrient consumption. All these affect the development of the child. Yes, and all that can result in neurodevelopmental delay. Some work has been done on imaging in these children, and some of the most common features that have been captured are periventricular leukomalacia, cystic in nature, but the finer imaging can also find non-cystic diffuse white matter injury in these children. Yes. And there's also been reports of oligodendroglial injury, and we have talked about the reduced myelination. Yeah, the reduced myelination in these children and axonal injury. But so we have a rough idea that neonatal sepsis could potentially result in neurodevelopmental delay. Yes. But the extent that it does that and the mechanism through which it does this are poorly understood. Yes. So we conducted this study in the context of the baby gel trial. You know? Can you hear me?
Yes.
Yes. So we conducted this trial in the context of the baby gel trial, which is a cluster randomized trial evaluating the effectiveness of household-based alcohol hand rub for the prevention of sepsis, diarrhea, and pneumonia. And I'll tell you just a little bit about it so that you have an idea where we are getting the babies that we are studying. So this study is located in eastern Uganda in 2 districts, and that's what is highlighted. That's where I am right now. And for those who don't know where Uganda is in Africa, that's Uganda, the green part in Africa. We are really in the heart of Africa. Yeah, we're in Eastern Africa, but really in the heart of Africa. So the baby gel trial is comparing whether providing pregnant women with birth kits that contain soap and chlorhexidine and yeah, so in one group, we are providing birth kits, containing soap and chlorhexidine. But in the other group, we are also adding alcohol-based hand rub. and training women or to use alcohol-based hand rub. Not only women, but everybody who interacts with this newborn. They have to use alcohol-based hand rub before they touch the newborn. And in these groups, we are going to compare the incidence of these infections, starting from neonatal sepsis. So we recruit these women when they are pregnant at 34 weeks and follow them up at birth. Then we have a telephone visit. No, we have a face-to-face visit at 1 week. We have a telephone visit at 2 weeks, another face-to-face visit at 4 weeks. So all the children that I'm going to mention in this pilot project, we recruited their participants, I mean their mothers when they were pregnant with them, followed them up to birth, visited them in the first 48 hours, visited them at 1 week, and visited them at 4 weeks, face-to-face. So it's really a well followed up trial, and on each of these visits, we screen for neonatal sepsis. Yeah, the protocol has been published, so if you want to learn more about it, yeah, that's the protocol, and we have recently published it. Yeah. So the research gap in our study was the absence or the dearth of knowledge about neurodevelopment among survivors of neonatal sepsis. Yes. So our objective was to compare neurodevelopment and neuroimaging between 30 infants who are hospitalized for neonatal sepsis and 30 infants who did not suffer from neonatal sepsis. And I just wanted to give a schema of how these studies are related. So we have the parent study, which is the baby gel cluster randomized control trial, and this is EDCTP funded. Yes, so in this group, we have some babies who get neonatal sepsis. They're about 12 to 15% who develop neonatal sepsis. And we have those who don't develop neonatal sepsis in the same cohort. So these are followed up to about 3 months. And yeah, we're assessing their neurodevelopment and neuroimaging. So this primary part was funded by EDCTP. Then Thresher Research Fund has funded this follow-up study. Yeah, and we thank then that NIH funded a lot of the imaging. Yeah, we're piggybacking on one of our co-investigators, our NIH project. Yeah. So how do we define neonatal sepsis in our study? So neonatal sepsis was defined as an illness associated with any of the following danger signs observed or verified by a study clinician. And in our case, it was a medical officer, a doctor. And the symptoms we are looking for were inability to feed, vomiting all intake, lethargy, unconsciousness, severe lower chest drawing, and auxiliary temperature either greater than 37.5 or less than 35.5, granting cyanosis, convulsions, or a history of convulsions, and results in hospitalization. And this must have been verified by the outcome verification committee. So, of course, in our study, all those that died in the neonatal period were not included. But the key takeaways was the neonatal sepsis was possible CV, was really likely neonatal sepsis because we did not have laboratory confirmation. We're not routinely doing blood cultures in this group. However, for them to be considered to have a neonatal sepsis, they should have been sick enough to have been hospitalized. Yeah, so all of them were hospitalized with neonatal sepsis. Yeah, all of them were hospitalized with neonatal sepsis. Yes, but again, it's really possible because we did not verify the neonatal sepsis. Yes. And the outcome, what are some of the outcomes that we looked at? Yeah, we looked at neurodevelopment using the Bayley's scale for infant development. We tried to get some functional assessment with NIAS, frequency domain near infrared spectrometry. And we also obtained some growth, weight for height and height for age. And we also obtained some, we really also moved out to get some brain imaging using the hyperfine MRI. And maybe I'll just show a little bit about how we went about this. So this is our team. Yeah, that we're working with. Here they're conducting a NIAS measurement. You can see domain infrared spectrometry also with DCS, and really it's a very non-invasive procedure. This is the probe. Yeah, usually it was in the presence of no light and darkness. We did this to just get a picture around it. And yeah, I mean, we'll take a number of measurements. At the same time as we're taking the NIAS, we also capture the blood pressure. That's the cuff here. We capture the SpO2 of the child. Yeah, and we also capture the respiratory rate. So there are some, yeah, we have attached some leads on the chest, and we are capturing the respiratory rate to really help us in the interpretation of the NIAS. Yes. And yeah, we just take multiple measurements along the hairline, and yeah, and record all this information. Then we'd also obtain anthropometry, and that is we get weight for height, height for age, weight for age, yeah, and using the standard RSECA scales and following the standard World Health Organization criteria. Yeah. We also do Bailey's, and yes, we also do Bailey's. This is a child who's going to do a Bailey's our examination and assessment, and we get sort of like the scores from that. Then we also conduct cranial ultrasound. Yes, we also conduct cranial ultrasound, and this cranial ultrasound has a Doppler component on each of them. Because they are 3 to 6 months, almost all of them have their anterior fontanelle still open. So yeah, and for many of them, we would easily get images. Yeah, so for many of them would easily get images. So maybe what may not have really come out very well was this was really a pilot. We wanted to see how we can do this in our setting. One, whether we can do it in our setting, and two, whether it can inform us. So, like I said, we have 30 participants who had neonatal sepsis at birth and 30 who didn't. And we tried to, so the ones who had sepsis were like exposed, but would match them to children in the same village on the same age who did not have sepsis, so that we have children who are having the same sort of our socio-economic status. Because socio-economic status is one of the biggest risk factors for poor neurodevelopment in our setting. Yes. So what are the preliminary results? And I must say, we have just obtained many of these results. We have just done this preliminary analysis, and we're looking forward for guidance, comments, and so many, learning a lot from your teams that have done this work previously. Yes. So what are some of the preliminary results? So I'm going to just present a couple of box and whisker plots. And the box and whisker plot, this middle line is the median. This is the median. The lower one is the lower quartile, which is the 25th percentile. And the upper one is the upper quartile, which is the 75th percentile. Yes. So first, weight for age. The ones with a blue shade are the ones who had sepsis, and the ones with a dark yellow or brown shade are the ones who did not have sepsis. And this is really Yeah, this score is 0. Like this is like the population mean. Yeah. So for the weight for age, we can see that both the children who have sepsis and those who don't have sepsis, they are relatively in at least the median is the same. Yeah, the median is the same. We consider the distribution slightly of those who didn't have sepsis was slightly higher, but yeah, relatively they are all they are very, very similar. And it's the same thing with length for age. So with length for age, yeah, this is like stunting. We call it length because almost all the measurements were taken with the child in the recumbent position, not standing. If you're standing, it would be height for age, but this is length for age. And it's recommended for children who are of this age, 2 years and below. Yeah. So, and we can see again, they are almost the same. Yeah, they are almost the same. We try to compare them using rank sum test or Wilcoxon's rank sum or the Mann-Whitney test, and there wasn't much difference between the two. So weight for length, this would be like wasting. Yes, we can see the medians are also the same, and the MUOC. Now for the MUOC, we see a slight difference, and slightly favoring student who had sepsis, but overall, when you look at the distribution, it's relatively similar. So when we looked at the growth, the weight for age, the length for age, the stunting and wasting, and really the MUOC of these two groups, we didn't see any. We're not seeing any difference. Yeah. So next we looked at Bailey's, the neurodevelopment, and the Bailey's were comparing the constructs of we're comparing the constructs of cognition, language, motor, and social. And again, I must repeat, these are about 30 babies in each group, so it's really a small sample. And it was just a pilot investigation into this. Yeah. So again, we don't see much difference in the cognitive. Yeah, in cognition. We don't see a lot of difference in the language, also motor, and really also the social. Yeah, the distribution is almost the same. And this really surprised us. We thought we were going to find at least some indication of difference favoring the children who didn't get any sepsis. Yeah. But we didn't see much of it. And maybe one of the things that I can mention that in this population, for the nutrition, almost all babies are being breastfed exclusively in this population. So they're having that benefit of a nutritional cover. Yes. So that's, and in most of our settings, we don't see a lot of malnutrition in children who are less than 6 months because of breastfeeding. Even both the rich and the poor, they're all taking breast milk and it's doing them very well. Yeah. So for the cognition, when we're measuring cognition, many times we're a bit reluctant to measure it very early at about 6 months, obviously, because it's difficult to measure when the children is very young, and especially using scales like the Bailey's, so it's a little bit difficult to check for differences and all that kind of thing. And finally, we did our Doppler. Maybe let me just adjust this image so that we can see what is at the bottom. Yes. So finally, we did our Doppler ultrasound, but also the frequency domain EI infrared spectrometry. So, and for the Doppler ultrasound, we would measure sort of the flow on the systolic and the diastolic. So we see there was a slight increase in the children who did not have sepsis. So in other words, they're having slightly better flow of blood flow. And here we are looking at the anterior cerebral artery. Yeah, we are looking at anterior cerebral artery, then the middle cerebral artery, and like here. So in the systolic phase, we see higher flow in the children who did not have sepsis. Even in the diastolic, we see a tendency, but this wasn't statistically significant on our man-Whitney test. Then also measured the CMRO2. Yeah, this is a measure of metabolism. It's one of the main things we get from the NIAs. Apologies, I missed the R here, RO2. Yes, and yes, so we see a tendency, there wasn't any statistical difference. They're almost in the same range. Yeah, but you could see the septic joints had slightly higher. And now this is the CBF in the frontal, and this is the saturation of oxygen in the frontal lobe. Again, we see the saturation of oxygen in the frontal lobe. We see a slight higher saturation in those who did not have sepsis compared to those who had sepsis. Again, these numbers were very small because, our NIAS machine got a problem along the way. So not all the 60 participants got a NIAS measurement. Yeah, which was a little bit sad. Yeah, but we see a slight tendency of better flow in those who did not have sepsis, and also slight tendency here in the saturation of oxygen in the frontal lobe. Yeah, again, these are preliminary findings. So the other assessment we haven't done is the brain volume assessment. Maybe I'll tell you a little bit about it. So we also want to compare their brain volumes. Remember, there are 30 who are hospitalized for sepsis and 30 who are not. Really want to see its feasibility, and and we hypothesize that those who are sepsis will have lower brain volume. Yeah, and so we have conducted MRI scanning at 3 to 6 months, and maybe I'll just say something. I'll just show. So this is the hyperfine MRI machine that we are using. And as you can see, it's a very simple thing. Like, it's a very simple MRI scan. It's fit in a simple place in an office. And this is actually a child that I was holding during the conduct of the examination. It's we have found some challenges in using it. Number one, it takes the sequences we're using are taking about 1 hour, only going for the T2 and the flare, and we take all we take the sagittal, the coronal, the axial images. So it takes a long time. Then the beeping sound, it has this beeping sound and noise that really irritates the child. So it's it's an interesting thing. And then here we are in the process of segmenting the images. So initially we thought we could get some AI tools that could help to automatically calculate the brain volume. But just know, because the images they're not of the best quality, because it's really they're low frequency, and really their Teslas are really, really low. So the images are not the best to deal with. So we have struggled with how to calculate the brain volume, but now we finally have our partners in Boston have developed they're using a certain manual, not really manual, it's a combination of manual segmentation and with some automation to it. Yeah, so we are going to do the segmentation. We have done all the images. Now it's the process of segmenting it. And this is a training we had sometime this week where we are going through the process of segmentation. And really segmenting is you look at the image, you at different cuts, and then you try to identify that all this is part of brain, then you sort of map out what other areas that you think are fluid, that have CSF. Then we subtract the total from the CSF and give you something on the kind. So, but that's the process. I'll be happy to hear how other people are doing it. Yeah, their segmentation, wherever they are. Yeah. So we have a big team that is doing this work. This is Andrew Hicks from Liverpool. This is Melissa Gladstone from Liverpool also. This is Yay Ivy Lynn. She's from Boston College. So she's really responsible a lot for the neuroimaging. She's the PI of the neuroimaging, and this is Dr. Smagai who's helping us. Dr. Smagai is a postgraduate of Melissa, and she's really helping a lot in this work. And below are our coordinators, Brenda, Faith, and this is the baby jail team that gets the children from the field, transports them to ensure they have the brain imaging. Now, this is the Boston team that, the NIAS machine is theirs, the Hyperfine is theirs, but it's at a hospital in Bale where I am. So I transport the babies there, and they've been very kind, with their resources. So that's the team that has been really instrumental with the conduct of the images, the Hyperfine and the and the NIAS measurements. Yes. All right. So that's it, and I'm very glad and looking forward to hearing your thoughts, your experiences. What can we look? What more can we look at? What else should we consider? Especially as we go deeper into the analysis. Yeah. Thank you so much.